Well, hello, I'm Paul Pronovo. I am a specialist in clinical hypertension in a section of the nephrology at Temple University and a member of the hypertension management program. And we welcome you to explore our new innovative program and approaches to hypertension for our community. I would like to discuss with you optimal pharmaceuticals to support blood pressure management. As you're all aware, high blood pressure is one of the strongest and most modifiable cardiovascular risks and risk of kidney disease. Blood pressure reduction with medications can effectively reduce this risk. And it's been estimated that each 5 millimeter reduction in systolic blood pressure conveys a risk of major adverse cardiovascular event reduction by 10%, reduction in the rate of strokes by 13%, and all-cause cardiovascular death by 5%, even when starting with low baseline blood pressures. And although hypertension awareness, treatment, and control have improved since the 1980s and 90s, control rates have plateaued in the past decade. Despite highly circulated guidelines with frequent updates on the treatment for elevated blood pressure, we continue to see wide variations in prescribing patterns, often with associated inadequate clinical results. Largely as a result of the SPRINT trial, we've now appreciate the need to be more stringent in our goal blood pressures so that the vast majority of people should have a targeted blood pressure below 130/80. Whether or not they have hypertension alone or hypertension with associated comorbidities such as diabetes, stroke, cerebral vascular disease, coronary artery disease, or chronic kidney disease. The approach has varied, but certain tenets remain very important in our approach to this. And the initial treatment usually centers around one of three classes of agents. Agents that block the renin-angiotensin converting enzyme, dihydropyridine calcium channel blockers, or thiazide diuretics. It's appreciated that each agent, on average, reduces blood pressure by about 10 points. And so for somebody who starts with more elevated blood pressures, certainly over 140 or 150, it's very likely that they're going to need combination medicines, and that there's an increased push to initially starting with combination medicines, particularly in the form of a single tablet. When we look at these various agents, several observations based on randomized controlled trials and observational trials are visible. One, chlorthalidone seems to have advantages over HCTZ as a thiazide diuretic and retains efficacy in advanced kidney disease. And although dihydropyridine channel blockers seem to have more efficacy at standard doses than non-dihydropyridine, such as diltiazem or verapamil, certain agents have been studied more commonly than others, in particular amlodipine, based on the results of the ALLHAT trial, accomplished trial, and many other trials looking at these therapeutics. Recent other trials, such as the Pathway 2 trial, has shown that spironolactone, a mineralocorticoid antagonist, may be superior to beta blockers or alpha blockers as add-on therapy. And as a result, spironolactone is often recommended as a fourth-line agent in conjunction with an ACE or an ARB, a thiazide, and a dihydropyridine calcium channel blocker if needed. As many of you are aware, ACE inhibitors and ARBs are not recommended in combination, largely as a result of the OnTarget trial and others which have shown an increased risk of acute kidney injury. Beta blockers in general do not have strong blood pressure reducing effects in most people and are preferred only in those with associated cardiac comorbidities. And while its other agents' use are often limited by side effects, agents such as clonidine have had similar rates of control as spironolactone as a fourth-line agent, but many of these other agents that we're left to use are added as needed and not really desirable because of significant side effects associated with them and more frequent dosing. Many of us are aware of common side effects of many of the agents we use to lower blood pressure. Thiazides may be associated with a variety of metabolic effects such as hyponatremia, hypokalemia, hyperuricemia, and hyperglycemia. These effects may be more prominent in older patients and in those with associated comorbidities. Calcium channel blockers of the dihydropyridine type may cause non-diuresable edema and often confuses primary care providers when they see swollen legs and attempt to use larger and stronger diuretics in attempt to deal with this. We've all seen side effects from the ACE inhibitors, such as cough, present in about 10 to 15% of the patients. And this could be easily remedied by converting these patients to an angiotensin receptor blocker. Very rarely, life-threatening side effects such as angioedema may be seen, but thankfully these are very rare occurrences indeed. There's no medication without side effects, but the other ones tend to have more of an adverse side effect profile. Beta blockers may cause fatigue and bradycardia, a slow heart rate, as many of you know. Mineralocorticoid antagonists such as spironolactone has been associated with tender gynecomastia and menstrual irregularities, and hyperkalemia when used in conjunction with an ACE inhibitor. But their risk remains low and that combination is often deemed acceptable. Peripheral alpha agonists such as Cardura may be associated with first pass effects with excessive blood pressure reduction and orthostasis where patients feel dizzy or lightheaded upon standing. Central alpha agonists or sympatholytics such as clonidine may be associated with symptoms such as fatigue, dry mouth, again, orthostatic changes in blood pressure, and risk of rebound hypertension, particularly when they come into the hospital and the admitting doctor discontinues this agent in favor of other agents. The direct-acting vasodilators, such as hydralazine, have very unpredictable responses in individual patients. They are associated with fluid retention and reflex tachycardia, and a variety of autoimmune diseases that are not infrequent, including ANCA-associated disease, ANA, and even retroperitoneal fibrosis, making these less desirable, also in part because of the frequent dosing that's needed. So when we look at agents of choice, a variety of principles come to mind that we try to exercise in our program, and most practitioners should keep in mind as well. First of all, the use of the medication should not be a substitute for lifestyle modifications, which can be very effective in reducing blood pressure. However, initiation of these medications should not be delayed while attempting to modify one's lifestyle and waiting for a response. It's also recognized that most blood pressure lowering occurs in the moderate dosage range, with a greater chance of side effects when prescribing higher doses. As stated already, most patients whose initial blood pressure is greater than 150 are going to require more than one agent to achieve controlled blood pressure, and therefore combination medications are going to be needed. The frequency and number of pills per day are important factors affecting patient adherence. So it's preferable to use medications with once daily dosing or single pill combinations with fixed dose combinations as needed. And the choice of agents used should have complementary mechanisms, such as an ACE inhibitor with a calcium channel blocker with the thiazide, for example. As already alluded to, consideration of agents should include acceptable side effects and, of course, financial concerns and encourage insurance coverage. And again, treatment goals for most patients with these agents is going to be less than 130/80. We could see from the START trial that starting combination therapy initially with either a variety of ARBs, ACEs, and amlodipine as a calcium channel blocker have been shown to improve adherence because of a lower pill burden and simultaneously reduce all-cause mortality to a significant degree. An interesting concept that has come up recently is called chronotherapy, due to the recognition that nocturnal blood pressure is correlated more strongly with cardiovascular risks than perhaps daytime blood pressure. The normal response to sleep is a 10 to 15% drop in systolic blood pressure. And the nocturnal response, of course, can only be assessed by 24 ambulatory blood pressure monitoring, which we're now able to offer at our hypertension program at Temple. So the absence of this nocturnal dipping, reverse dipping, where the blood pressure actually even goes up, or excessive dipping, where it's reduced more than 20%, all has a variety of increased cardiovascular risks attributed to it. A recent trial called the Hygieia one suggested that taking your medications in the evening may have therapeutic advantage by providing more strict control during the nighttime and high-risk period. However, methodologic problems to this study and the risk of excessive reduction we just discussed allow no firm recommendations to be made as yet about the timing of blood pressure administration until the results of 3 ongoing randomized controlled trials are published. So Temple University's comprehensive hypertension program has its goal to partner with referring providers to obtain optimal blood pressure control in order to reduce cardiovascular, cerebral vascular, and renal disease that all is attributed to elevated blood pressure, with a focus on those who have resistant hypertension, meaning inadequate controlled blood pressure not at goal despite 3 or more medications of reasonable combination, one of which being a diuretic. We use a multidisciplinary team approach with hypertensive experts from a variety of clinical backgrounds in partnership with community resources, pharmacists, and dietitians. This allows a broad array of consideration of diagnostic and advanced or emerging therapeutic options. We encourage the use of home blood pressure monitoring and offer ambulatory blood pressure monitoring services to our patients to achieve adequate and comprehensive control. Thank you for joining me in this discussion, and thank you for partnering with us in our attempt to adequately battle one of the more common cardiovascular risk factors that plague our community. Thank you again.